Welcome to Path to Medicine, the podcast where we explore real stories from healthcare professionals to help young people understand the world of medicine. I'm Sarah.
And I'm Zara.
And I'm Ashana. Today we're joined by someone whose work has shaped healthcare globally, Dr.
Sure.
Bogdan.
Dr. Bogdan is a British physician, global director, and clinical lead at the National Academy for Social Prescribing and an honorary lecturer at UCL.
He's collaborated with the Harvard Global Health Institute, led the NHS Social Prescribing Champion Scheme with over 20,000 professionals, and was named one of the top 100 most influential people in health in the UK.
First of all, thank you so much for having me, and well done all of you for organizing such a wonderful
It goes
podcast.
far beyond clinical work, from hospital medicine to influencing global health policies. How would you say your journey evolved from medical school to leading these major initiatives?
Yeah, it's really interesting. If you were to ask me in high school what I wanted to do, I always wanted to be a surgeon. And I'm not a surgeon right now, right? I'm an emergency medicine doctor. I work a lot in primary care. I do lots of things. So I think what's fascinating is that your perception of what you think you like will change, and that will change based on what you get to do and what you get to experience. So we will have perceptions formed by or influenced by the people that we meet, the relationships that we have, the films or TV series that we watch. It might be Grey's Anatomy, it might be House MD, whatever you think will float your boat, may eventually not be what you were hoping for. And so for me personally, interestingly, although I was doing a lot of suturing and stitching bananas when I was in high school, and I always wanted to be a surgeon, I had this moment in medical school in my third year of medical school where I spent my whole summer with the best surgeon in Europe for orthopedic malignancies. It was a very, very specific niche. He was working in Vienna. He was a surgeon at the HKH hospital in Vienna, one of the most renowned hospitals in Europe. And I was fascinated because I was in the morning coming in at 7 a.m. He was already there from 6:30 or 6 a.m. in the morning. And then I would leave at probably 8 or 8:30 in the evening. And one day I asked him, so when do you have time to do your other projects or your other things that you love in life? And he said, what do you mean? And I said, your other projects, maybe you like public health, or maybe you like I don't know, your other hobbies or other things that you like doing, your other interests in research or teaching. And he said, what do you mean? He had this very strong, funny Austrian accent. And he said, what do you mean? This is what I love. This is my life. And I thought, well, fair enough. That does make a lot of sense, actually. That's what he loved. And that's what brought him joy. And for him, going then from morning to evening meant he was the best surgeon in Europe. But that came as a cost, or came with a cost associated to it. So that's the point when I realized that everything in life that you will do has to come with a cost associated to it. And so it's up to you how you balance your priorities, and it's up to you how you'll be balancing what matters to you the most. And so at one stage in your life, when you don't have a family or don't have a relationship, you may think you never want a family or a relationship. But guess what? You're going to meet that person that's going to turn your world upside down, and then you're going to want a family. And then you're going to be thinking, well, do I want to be in hospital until 11 p.m. every single day? Maybe not. Maybe I want a child. Maybe I want to, or maybe I have other interests. And so I think back to your question, for me, I just realized that for me, if I wanted to do something, I always wanted to be the best at that particular thing. And I realized that if I picked surgery, it would limit me in the sense that I wouldn't be able to do it 100% because I wanted to do other things on the side as well. Hence why I've decided to choose what I call probably a portfolio career. My brain works in such a way in which I don't like feeling bored. So I always purposely get myself to be as busy as possible. And it's quite funny, if I don't have a packed day or a structured schedule and I don't know what's happening in that week, I'll probably end up wasting a lot of time. So I realized that the most productive weeks for me, and the best weeks and the best days that I have, are always where I do lots of things that fill me with energy. And that includes a combination of my clinical practice, my policy work, so working with the government, supporting policy development, preventative care, community-based medicine, my teaching students like you, supporting tomorrow's healthcare leaders, and seeing young people with great potential, such as yourselves, giving their absolute best, and one day doing things that I haven't been able to do by the age of 30 or 35, and so on and so forth. And I've realized that the combination of those things are what fill me with energy, rather than taking away energy from me, and it gives me more joy to get involved in elements like this. So that multitasking, that juggling for me is very important. And of course, every single day, I still find time for my hobbies. I still find time for my family, which again is very, very important, and has been a key part of my value subset, I guess.
That's really inspiring to hear. A lot of students imagine medicine as a fixed, linear path. When did you realize you wanted to work on something as innovative as social prescribing?
It's a fantastic question, and I think the answer is zigzagging through life. I think you have to realize that everybody does things that are preset for them, or prescribed for them. So, for example, you go to kindergarten, then you go to primary school, then you go to secondary school, then you go to medical school. Then success looks like what? Well, I'm going to be successful when I'm going to be a doctor. Okay, now I'm a doctor. Then what? Well, now I'm going to be successful when I'm going to be this kind of doctor. Maybe I want to be a heart doctor. Okay, I'm going to be successful when I'm going to be a heart doctor. Then you become a heart doctor, and then you're thinking, well, now what? Because okay, well, I can be the best heart doctor. Fine, you become the best heart doctor. Then what? So I think what I've realized is that if you follow this linear pathway, you're chasing happiness and you're chasing success. And I think the biggest joy you get from life is when you're being happy with yourself in the moment and the little things that you're doing on a day-to-day basis. So my love and my passion for social prescribing and community-based medicine came from actually not passion, but frustration. So you know how people always say, follow your passion? I actually disagree. I think you should follow your frustration, because that's the thing that you are angry about, and therefore you're filled with this fire from inside that you want to change. And for me, it was a frustration of nonstop in medical school, seeing patients on this revolving door that we call hospital, and they would come in, one out, and then we'd prescribe some medication for them, but then we know that wasn't the root cause of their problem, but then we'd shoot ourselves in the foot and then send them back home anyway, and then they'll come back next week with the same problem, because we didn't really actually solve the problem. We just patched up the problem, we stick a plaster to them, and then off you go to the community, and go back home, and somebody else will pick up the pieces, but actually we end up picking up the pieces again. So I shortly realized in medical school that the things that we call social determinants of health have a huge impact on our lives. So what we eat, how we sleep, how educated we are, how much money we have, whether we drink, whether we smoke, those things actually, based on research, have an effect of 80% of your health is attributed to those social determinants of health. Only 20% of who you are is based on genes, is based on science. So if you have genetically identical twins who one lives in Japan, one lives in the US, and they eat completely different things and they smoke, one doesn't smoke, one smokes, you'll find completely different outcomes, although they have been genetically identical. So that's, I think, where my fascination with this idea of social medicine and the impact of our psychology, as well as our social circumstances that can have on your health. And then from then onwards, I just decided to reach out to mentors and do more research on the topic. And the rest is history, I guess.
So you've helped embed social prescribing into medical school curricula as well, from what we've learned about you, and advise global systems. So we wanted to ask, what's one outcome from this social prescribing that makes you think this is making a real difference?
Absolutely. Great questions, Zara. And from my side, I just want to make sure that your listeners are familiar with the concept of social prescribing and that they know exactly what it is. So in very simple terms, if you forget everything from this podcast, what social prescribing is an opportunity for us to support people who don't have a biomedical need. So somebody comes through the door, they might come in with a headache, or they might come in with a high heart rate. But once we've done all of our tests, they all come back normal, but clearly the patient doesn't feel normal. They still have a headache. They still feel low mood. They still have anxiety. So in such circumstances, we would normally prescribe a medication, they'd go back home, and then they'd come back to us because the medication doesn't do anything, because they didn't actually need the medication, because their problem is not biomedical. Their problem is social. It's either anxiety related, a panic attack, it might be finances worries, it might be a tough time that they're going through life, it might actually be, for example, loneliness or isolation. They might need practical support or other elements. And in such cases, we are able to prescribe a social activity. So you might prescribe art on prescription, gardening, gym classes if somebody's trying to lose weight, cooking classes for them. You might prescribe befriending services. So young students like you go and talk and support elderly populations. And so what we've seen, which is why I believe social prescribing is absolutely crucial, and we're seeing lots of movement around this theme around the world, is that in areas where we've embedded social prescribing, we've decreased emergency attendances and unplanned attendances in hospital by 25%. And that's what all the studies are showing on PubMed and in research. And we've decreased doctor attendances, not emergency medicine, but just normal doctor attendances in primary care by 40% in the areas where social prescribing was used. That's saving millions and millions, if not billions of pounds to our healthcare system in the UK, not to mention the adverse outcomes that are being saved for the patients themselves. And if we had a pill that could do this, that could decrease your appointments with doctors by 40%, I think I should be in the run for a Nobel Prize by now. But social prescribing is not a pill. It's not as sexy or as fashionable as a pill. There's no pharma company behind it. There's no hype behind it. It's just good old simple community care, friendship, befriending, being a good neighbor, supporting people with what really matters to them. And instead of a weight loss injection, we're actually talking about diet and nutrition and exercise and the things that will keep us healthy in the longer run, which of course aren't the bulletproof mechanisms that would give you results from the first day and require grit and determination. So maybe that's why it's not as fashionable.
Introducing something new to medicine must come with challenges. What were some of the toughest obstacles you faced, whether it's bureaucracy or personal doubt, introducing social prescribing into the field of medicine?
Thank you, Sarah. The obvious one that comes to mind, just as you're talking about that, is the resistance from current clinicians who were trained on a different pathway. So if you think about it, lots of things have changed between the generations. And I think it's not about how easy or how hard it was for them. It's not them versus us. But I think what's fascinating to look at the former generation of physicians is that there were textbooks with this is how many muscles we have and how many blood vessels we have. And this is what to do if this happens. And it was very algorithmic. It was very if X, then Y. Well, funny enough, nowadays, we actually have everything at the click of a button. And you have ChatGPT and you have AI and you have all of those nuances. And medicine, we realize more to this day that it's very nuanced and it's very gray. Yes, it was always like this, but now we have more opportunities. And so what was fascinating to see was that back in the day used to be this hierarchy of I'm wearing a white coat and I've got pens lined up here and I'm the doctor and you're the patient, and I'm telling you what to do. And if I tell you, then you should do it. Well, that's changing because nowadays patients actually have more access to information than ever before. And if you come to my clinic and you say, I've read about this, what should I do? I'm not going to say, well, why don't you let me do my job as a doctor and you do your role as a patient, right? I should be actually empowering you and working together with you because it sounds like you're ready to engage. And instead of putting you down for that, I should be supporting you. So what we found fascinating was that the traditional model used to be there's a pill for every ill, which doesn't work like that anymore because we know, as we said, many of our issues, in fact, 1 in 4 people come to the doctor for pure social reasons. So if 1 in 4 people come to the doctor for pure social reasons, that means 25% of all the patients out there are being over-medicalized when you shouldn't be doing that. But traditional doctors and traditional patients, so maybe look at your grandparents, when they go to the doctor, what do they expect? The doctor took my blood pressure. They gave me a pill, so I'm going to feel better with the pill, right? Now, if somebody comes to me as a doctor and they've got a headache, and then the headache doesn't go away, but they come back to me and I give them another pill for the headache, different from the first one, then they come the third time to me and I'm giving them a third pill, fourth pill, fifth pill, sixth pill, seven, so on and so forth. It then means that their problem may have not come from a pathology. It may just be that we're over medicalizing things. And so this perception, both in terms of old-fashioned patient, but also old-fashioned doctor, were some of the issues that we were facing. Some of the doctors were criticizing the movement behind social prescribing and social determinants of health, to say that, for example, is not the role of the doctor to get involved in patients' affairs. And that's all about politics. The fact that people don't have good housing and therefore they have mold or dampness in their house, that's the government's fault. The fact that people don't eat well and the fact that they don't have enough money to buy good food, that's not the doctor's problem. That's, again, based on a political issue, which is, yes, we call those things political determinants of health, but surely we can teach people how to eat healthy using little money too. And surely we can support people to prevent those issues in the longer run. And we know that diabetes, cardiovascular disease, obesity, all of those conditions have as precursors some of those lifestyle factors. And we know that they appear mostly in those from lower socioeconomic backgrounds and also from lower educational backgrounds. Because, of course, if you don't have that much money, are you going to choose the donut, the Mars bar, or are you going to choose the blueberries, which cost 5 times more? And also, you don't actually know that the blueberries are as healthy for you because you never learned about it in school, because you didn't really go to a school, right? And so it's fascinating to see that in action and to also see how the roles of doctors, from telling to working with the patient, that's how it's changed over the years. And I think that resistance was a big problem for us. Certainly from 2013, 2014, all the way to 2019, there was this battle between clinicians around, well, should we be doing this? Should we be not doing this? Is it really my job as a clinician to get involved in people's housing and talk to them about house repairs so that they don't have mold and dampness in their house? Well, sure, let's say you don't. And then you've given them, let's say you have an asthma patient and you've given them the top inhalers and the top amount of steroids and pills that you can give them. But that patient comes back to you again and again and again and again. Why? Because their asthma is generated and exacerbated by the mold and the dampness in their house. You can give them the best pills in the world that you can give them, but you're then shooting yourself in the foot because they then go back home and their house is shattered and they've got mold and dampness in the house. And they probably don't know that dampness and mold causes their asthma because, once again, they're not from that demographic. So here's where we as doctors would really fail patients. And that was part of my frustration of, it's not right, it's not okay. And I'd rather not practice medicine than close my eyes and just do harm to people, because I took an oath. When I decided to go into medicine, the oath was do no harm. And so if I'm closing my eyes and I'm just saying, well, have some pills, off you go, well, it doesn't really work like that. And I think that criticism is no longer there. I think the generations are changing, slowing, and even the older physicians are realizing that the changes in the world have had a big impact on the demographic, and so we are now adapting to this newer circumstances.
So medicine is often described as both a science and an art. And through your experiences and from what we've heard so far, from patient care and to policy, what have you learned about the human side of healthcare and how has that influenced how you work?
It's a fascinating question, one that I think has kept me in medicine. I think I am more fascinated by the art of medicine side than the scientific side. Although I've held scientific outcomes to high regard, and we use that in our day-to-day practice, I think you can have the best drugs in the world, but if somebody's not going to take them, then what's the point? So I think this is where the art of medicine comes in, the art of communication, the art of persuasion, the art of Sherlock Holmes, digging, finding clues, picking on the clues that you have around the bedside. There's a pack of cigarettes there. Ooh, but they said they stopped smoking last time. Interesting. All of those behaviors that we notice in our patients. And I think what's very interesting as well is that we are very privileged to have access to the most intimate details of their lives. There's no career like that. So with that power, I guess, as the famous, I'm not sure it's a philosopher, so it was a Peter Parker in Spider-Man, but with that power comes great responsibility, right? So I think what's really interesting is that if you do have access to that information, you have to be really careful how you use that information, and it makes you really humble to be able to support people through the toughest moments of their lives, but also the most joyous moments of their lives. So you see people from cradle to grave. For example, in my clinics today, I saw all the way from babies, 2-week olds, 3-week olds, 5 months olds, all the way to 91-year-olds that came to the clinic. So it's a profession like no other. And I think what's really interesting is this behavioral aspect of medicine that once again comes into how we treat individuals. And we've seen the laws of science be defied a bit, but by this behavioral side of medicine. It's all explained scientifically, of course, and social medicine does also have rigorous research behind it. But I think it's very interesting that we can sometimes bend treatment outcomes based on our relationships with our patients. And so that's why that patient report, that's why the trust with the individual is absolutely crucial. And that's why we as doctors need to not only just have the books behind us, but we have to be personable. We have to be treating the human being in front of us, not the disease. Yeah. So I think that's why we call it person-centered care. It's you're treating the person in front of you. You're not treating the DNA. You're not treating the disease. You are treating what matters to them rather than what's the matter with them. It's not just a label. You need to focus on what matters to them. And I guess a great example for that is if somebody comes to you with a headache, we always get taught to ask, well, what is it that concerns you? You know, is it the pain? Do you need painkillers? Oh no, actually, doctor, the pain doesn't bother me. I just want to make sure it's not cancer. Oh, interesting. Okay, well now I know. And rather than giving you the pill, which you didn't want from the beginning, maybe I should just do a scan so that I give you peace of mind, right? Or I could offer you some peace of mind. So I think this idea of matching your expectation with their expectations and matching agendas is absolutely crucial. And that's part of the art of medicine.
Would you say that there's a patient story or a personal encounter that stayed with you and reminded you why you do this work?
Absolutely. Tons, but I think my absolutely favorite one is a child. I won't give you his name just because of confidentiality, but we'll call him Ben. And it's a 9-year-old child that to this day stays with me. And he was an asthma patient, and I saw him in the emergency department. By the time I saw him, it was the 8th time. So he was seen 8 times before me over a period of 5 to 6 weeks. So almost twice per week, he would come in, same story all the time, shortness of breath, severe increased work of breathing. He was struggling to breathe. Asthma exacerbation is very clear. The diagnosis was super easy. The medicine was very easy. But the question was, why are you here every single week? And so I looked through the notes. All of the previous doctors that saw him for 8 times said, they've treated their asthma exacerbation. They would send him back home. Nothing would happen. I decided to spend 5 extra minutes, and I asked our community team to pay him a visit at home. And what they found was absolutely horrific. There was mold on the walls. There was cigarette smoke in the room. There were cigarettes from the parents that were smoking, and who came from quite a low socioeconomic background, so they didn't know that the smoke was causing harm to their kid because they said he wasn't smoking, they were smoking. But of course, there's passive smoking, and that they were exposing him to. And I remember what happened was that there was smoking cessation clinics for the parents, repairs to the house, and then I received a letter 8 months after from his family doctor to say a huge thank you because he's never ended up in the emergency department again. After that, his inhalers were taken down a notch, and he was able to control his asthma. And to this day, he hasn't returned to hospital with an asthma exacerbation. So that was a big win, but you're only seeing the good things. The bad side was that actually, I remember I was quite junior at the time. I was a junior doctor when I did this. It was a few years back. And I remember the lead doctor in the emergency department said to me, what was the point of wasting 5 extra minutes with this patient when we have such a long list of other patients? You could have just sent them home. You've treated them. it's not our problem now, not our job. So I got reprimanded for spending 5 extra minutes to find out what was the root cause of the problem. And I didn't even argue back because obviously I didn't know what the outcome was of what was in the house, right? I didn't see that. But I smiled sweetly when I look at it retrospectively. But that story in itself just tells you how wrong we are when we just patch things up and we just play this ticking bomb hot potato game of, well, you have them, well, you have them, or we just send people home and back to what made them sick in the first place.
You've mentored countless students and young doctors. So, what key lessons do you try to pass on to the next generation?
The most important thing for me is to start early, like you're all doing. So you are the inspiration for me, not vice versa. I'm inspired to see people like yourselves who are starting very early and very young. I started quite early, but definitely not as early as you. And that's my key message to young people is to build things that take time. You live in a world that actually you have everything at the click of a button, and it will be very painful for you to keep that patience when the reels are instant and the dopamine flows through your brain very quickly. But I promise you, things that take time and require patience will give you the biggest joy in life. And so if you try to do hard things and set a goal for yourself, and something like getting into medical school or something like a project or helping the local community or this podcast, yes, it's not easy to do those things over time, but once you've done them, you will get instant gratification from it, and it will make you build resilience over time, and it will also help you find mentors, which brings me to my second point, which is you need to surround yourself with people that you're inspired by. You need to surround yourself with a good type of friends, so like yourselves, you all have great interests and you surround yourself with like-minded people. I would say keep doing that, and you always want to be the youngest person in the room and the one with less knowledge than others, because then you're learning a lot from those more senior than you. I was very lucky to have very good mentors in medical school, and I learned a lot from them. And that's what I'm trying to impart now to you guys, so that in the future you can be on TV or in the news, and I can say, "Oh, I've met Sarah, Ishana, and Zara, and I used to teach them. Look now, they're like health ministers or whatever you guys gonna end up doing in the future." So that's what brings me joy.
As you know, many of our listeners are teenagers or early university students. So, what's one piece of advice you would give someone who's curious about medicine but is unsure where they fit or don't know where to start?
Absolutely. My top tip is to try it out. You're not going to know if you like it unless you try it. Same with banking, actually. Same with lawyering, or same with computer sciencing. So whatever career you're thinking of doing, you have to try it out. And so I'd encourage you to seek work experience. There's loads of placements. We do plenty. Some of you will know at Cleveland Clinic Abu Dhabi. If you leave that Cleveland Clinic Abu Dhabi placement for one day thinking, oh my gosh, that was so cool, I want to do this again, or conversely, oh, that was a bit gross, I don't want to do this, then you know. And so you at least you know, right? But you can't know what you don't know. So you don't know what you don't know. You need to experience things out. And the other element would be make an impact in your local community, set up a project. This, what you're all doing, the podcast, is a great example of a personal project, and that improves your skills, get you guys to speak, come out of your shell, but you're also making an impact on the wider community. So those would be my top tips. And third one, which I pointed out earlier, find a mentor and get mentored, and surround yourself with like-minded people.
It's been great to ask you all these questions. And just to end, what first inspired you to pursue a career in medicine?
Thank you very much, Sarah. It's a question that I think I've asked myself several times as well. And did I always want to do this? Definitely no. I think it was more by default, because I've been surrounded by doctors all my life. And that was for the unfortunate case that a lot of my family members were poorly. I was poorly when I was a child. And so I had the chance to see not only doctors, but more widely, nurses, healthcare assistants, all of the team working together to provide care to patients. And I think just seeing them combine their science knowledge with the ability to explain to younger me, and maybe 13-year-old me, being able to explain the what asthma was at the time when I was asthmatic, and make funny faces and jokes around me so that I could understand them, was what proved to me that medicine is probably more than just a science. It's also, like you called it, Zara, earlier, the art of medicine. And I think that made me want more. And it only came about after many, many placements, many trial and errors. I thought I wanted to do surgery, but then lost interest very quickly. And I loved this idea of emergency medicine, then community-based care. And so it was only by exposing myself to those areas that I realized I want to do this. And actually, it's one of those things that I would recommend to anyone to do medical school. It feels like doing the army, to be completely honest. It feels like joining the army. There's some discipline that comes with doing medicine because it's not easy. It takes time. It's really hard. So you're required to persist, fall many times. And if you don't know the story, you should by now that I actually didn't get into medical school the first time I applied. Yeah. So, and here I am with 5 books written to date on how to get into medical school, teaching people like you on how to get into medical school. But the truth is, I didn't get into medical school when I first applied. Isn't that ironic? Isn't that funny? Does that makes me a less successful doctor? Actually, not. I was named top 100 most influential people in health in the UK. So I don't think that made me a less successful doctor. If anything, it probably made me a better doctor because I was humbled and there was that slap to reality that I need to study for the UCAT, I need to study for the interviews, I need to study hard for my grades. And so I learned it the hard way. And so if you fail, remember, there's always a chance to get up. And when I was at your stage as a teenager, maybe this is a nice thing to end with, I think it's fair to say this is the hardest time of your lives. I will give you that. Everybody expects you to know what you want to do in life. Everybody expects you to perform. You're doing geography and history and maths and biology and chemistry and this and that and random subjects that you probably, some of you have no interest in. Well, that's about to change. So as soon as you reach university, you decide what you do. And if you don't want to do something, you don't do it. Right. And so things will change, but you have to delay that gratification for now, say no to the slice of cake to eat the bigger cake. And the more you can hang in there now and invest those years in high school for your future career, I promise you're going to have lots of fun in medical school or in university, whatever course you do. I promise you'll make lots of friends, cook international food, go out, have fun, join societies. But until then, whatever work you're putting in now, it will show. And don't make the same mistake that I did, which was play football because I really enjoy football. And the interviewers and the admission tutors told me at the time, no, you could just be natural. Don't study for the UCAT. Don't study for the interviews. And so I did. But clearly, it didn't really work out. So I learned the tough way. So don't repeat the same mistake that I made. And I wish everybody all the very best with their applications. And if anybody wants to learn more about how to get into medical school, there's the book on the unofficial guide to get into medical school, which is found in bookshops and places around. So please do have a look. And there should be a copy at DC and in most schools around the UAE. So do have a look in the school's library as well.
Dr. Bogdan, thank you so much for sharing your story and insight with us.
And we hope today's episode shows you that medicine isn't just a one-size-fits-all path. And I really took to home your advice about following your frustrations. And I really love that idea. I think that is something that's so inspiring to hear from you.
My pleasure completely.
Thank you.
Sarah, Ishana, Zara, it was so nice to be here with you all and wishing you all the best.
Thank you so much for being on the episode.
Join us
Thank
next time
you.
as we continue exploring real journeys shaping the future of healthcare.